Hi, my name's Henry. I'm a radiology registrar working at SA Medical Imaging, and this is the next in our series of musculoskeletal talks, this time on the knee. Thanks again to my colleagues Christopher and Meredith for putting this talk together. So, talking back to our learning outcomes, the outcomes for today are to explain the utility of imaging modalities in MSK imaging about the knee, and particular to the knee, talking about tibial plateau fractures and distal femoral fractures. We'll specifically talk about the Segond fracture as well. We'll talk about knee and patellofemoral dislocations, and a quick talk about some of the arthritides around the knee as well. So there are different modalities used to evaluate the knee. Primarily, or most people's first modality will be X-ray. And depending on that and their clinical presentation, either MRI or CT. Bone scan can also be useful in a number of cases, and what we've not mentioned here is ultrasound, which is particularly useful for assessing some of the soft tissue structures around the knee. So looking at plain radiographs initially, so just to orient ourselves, this is the medial aspect and the lateral aspect of the knee. You can tell that because we've got the fibula on the lateral aspect. We've got the distal femur here. We've got the patella, which is probably better seen in lateral or skyline views. We've got the tibia and fibula. We've got the lateral compartment, or the lateral tibiofemoral compartment, and the medial tibiofemoral compartment, and the patellofemoral compartment we see on these other views as well. Again, just saying the lateral tibiofemoral compartment, medial tibiofemoral compartment, and the patellofemoral compartment between the patella and the femur. A joint effusion is usually seen on radiographs in the suprapatellar pouch, which is contiguous with the joint. Normally, we have a pretty small sliver of density here, which expands with a large joint effusion. A lipohaemarthrosis is seen in multiple joints, but more often in the knee, and it's an indicator of an intra-articular fracture. It's where blood and fat escapes into the joint, and fat, which is lighter or less dense than blood, floats on top of blood. So we have a fluid level that we see. So in this suprapatellar joint effusion, we've got a fluid level with the less dense fat sitting on top of the more dense blood. We can also see sometimes multiple fluid levels, particularly in the setting of a hematocrit level, where we have blood separating out into its constituent components. So we can have multiple fluid levels, with the least dense being fat on top. It's nicely demonstrated on CT. Again, in this suprapatellar pouch, we've got this fluid level with fat and blood. MRI is also very useful in assessing the knee, and it provides more information regarding the soft tissue structures around the knee, particularly the articular cartilages, the menisci, the ligaments, cysts, bursitis, and also in assessing bone tumours. Can also give us more information on bones, particularly in bone marrow edema and osteonecrosis. On our sagittal MRI, we can see nicely the anterior and posterior collateral ligaments, not seen on the same sagittal slice. Can also see some tendons around the knee, so the quadriceps tendon, the patellar ligament, again the PCL seen, and you can see some of the muscle bellies around the knee as well. Coronal MRI can also see the ACL and PCL in cross section. We can see the menisci, these dark triangular structures. Again, you can see muscle and tendons around the knee, the median lateral collateral ligaments as well, and again, assessment of some of the bones and cartilage. Axial, we can look at the patellofemoral joint in more detail, look at the medial and lateral femoral condyles, the iliotibial band, and again tendons, ligaments, and muscles. So the normal structures around the knee, the ACL is parallel to the intercondylar roof and has a striated appearance with some signal within, which is a normal appearance. The PCL conversely has a uniform hypointense signal and has a gentle curve. The MCL can be visualized normally in its entirety in the coronal plane as a thin, well-defined, low signal intensity structure surrounded by fat. You can also see the PCL and the lateral stabilizing structures of the knee are sort of more complex. The menisci around the knee are act as sort of cushions between the tibia and femur, and are seen as these well-defined, dark, triangular structures in cross-section. The medial meniscus, both horns are relatively triangular, with a sharp point, with the posterior horn greater or larger than the anterior horn. Lateral meniscus, they're both about the same size, and we can see that they're relatively uniform in signal intensity. Meniscal tears are seen as sort of fluid signal or defects in this otherwise normal homogeneous signal intensity. On axial imaging, the lateral meniscus is a symmetrical C shape, and the medial meniscus is seen more as a comma shape with a larger posterior than anterior horn. The patella is stabilized by a complex sort of ring of structures. It's got the quadriceps tendon, the patella tendon, and then it's got medial and lateral patellofemoral ligaments and medial lateral retinaculum. Distal femoral fractures can occur as a result of old people with reduced bone density or insufficiency fractures, or younger people with high velocity or high force trauma. They're classified as either supracondylar, condylar, or intercondylar. And there's an AO classification as well, based on the amount of, based on whether it's extra-articular or intra-articular. And the AO classification has many sub-classifications as well, probably too much to go into today. Tibial plateau fractures are as the result of axial loading, i.e. a fall from a height, and have associated soft tissue injuries in about 10%. The lateral tibial plateau fractures more commonly than the medial, and plain films can often underestimate the severity of injury, and CT is usually used to define the extent of injury and for surgical planning. They use the Schatzker classification of tibial plateau fractures. So this is the Schatzker classification of tibial plateau fractures. Type 1 is of the lateral tibial plateau. Type 2 is lateral tibial plateau with a depressed segment. Type 3 is a depression of the lateral plateau. Type 4 is a fracture of the medial tibial plateau. Type 5 of both tibial plateaus, and type 6 is where there's been interruption between the metaphysis and diaphysis. The patella is a sesamoid bone that sits sort of in the quadriceps tendon and patella tendon. Its upper pole, like I said, attached to the quadriceps tendon and the rectus femoris and vastus muscles, and the lower pole to the patellar ligament, which inserts on the tibial tubercle. Patellar fractures are usually as a result of direct injury, either a fall from a fall onto knee, or indirect injury as an avulsion fracture. X-rays may be occult on plain films, and CT can be informed if it's injury suspected but not seen on plain films. Important to not confuse a bipartite patella with a patellar fracture. Bipartite patella is seen in about 2% of the population and is the result of non-united ossification centres. A key with the bipartite patellas is that they'll be seen in the upper outer quadrant of the patella. A Segond fracture is an avulsion fracture of the lateral rim of the proximal tibia or the tibial plateau, and it's an avulsion fracture of some of the lateral capsular ligaments. It is important because it has a high degree of association with ACL injury or tear. Mechanism is internal rotation with varus stress, seen in sports where you're rapidly changing direction, like skiing, basketball, or in some falls. Pelligrini-Stieda lesions are post-traumatic lesions, ossified post-traumatic lesions at or near the medial femoral collateral ligament, adjacent the margin of the medial femoral condyle. Most patients will be asymptomatic, while a small proportion will have medial knee pain. And on plain films, we can see calcification adjacent the medial femoral condyle, often linear or curvilinear, paralleling the femoral cortex. These are post-traumatic and with one mechanism of injury presumed as an avulsion fracture of the medial collateral ligament. Calcification usually starts 3 to 4 weeks post-injury. Postero-lateral corner injuries account for about 15% of acute knee injuries, often sports-related injuries and related to direct tibial impact trauma at the anteromedial aspect. They often occur in association with an ACL or PCL injury and can result in extensive ligament disruption of the posterolateral ligaments. There's not really a consensus on what constitutes the posterolateral ligament complex, but the main three structures involve the lateral collateral ligament, the popliteus muscle, and the popliteofibular ligament. They're important injuries as there's the potential for long-term joint instability if they're not identified and treated. And MRI would usually be involved in further assessment of these lesions to review sort of soft tissue structures that have been damaged. On plain films, things to look out for that should raise concern for posterolateral corner injuries are Segond fractures, avulsion fractures of the iliotibial band, and fractures of the anteromedial tibial plateau and femoral condyle. Patellar dislocation accounts for about 3% of knee injuries and most commonly results from a twisting motion, particularly with the knee inflection and the femur rotating internally on a fixed foot. There are risk factors for recurrent dislocations, which include trochlear dysplasia and patella alta. And dislocation commonly occurs as a result of disruption to the medial patellar retinaculum. Plain films demonstrate a lateral displacement of the patella on frontal or skyline projection, can also be associated with a joint effusion. MRI is helpful in looking for things that predispose to patellar dislocation as well as sequelae of patellar dislocation. Things like joint effusions. We've got so-called kissing contusions where the bone's been sort of hit up against each other. We have sort of matching contusions. So here in the lateral femoral condyle, and we may see a associated contusion or another contusion in the inframedial portion of the patella where they've been butt up against each other. We can see that there's tears of the medial patellofemoral ligament or medial patellar retinaculum, and sometimes you can have associated fractures or impaction fractures in the inframedial patella. Knee joint dislocation is relatively rare. It requires a high force injury, usually forced hyperextension, and has severe soft tissue and ligamentous ruptures. Most notably, there are associations with neurovascular injury. The popliteal artery, as you know, runs right behind the knee, so dislocation puts that artery at risk. And obviously reduction is required. Osgood-Schatter's disease, or apophysitis of the tibial tubercle, is due to repeated microtrauma at the Patellar tendon insertion on the tibial tuberosity, usually in children between the ages of sort of 10 and 15. Particularly in those who jump and kick. It can occasionally be bilateral. Clinically, they present with pain and swelling over the tibial tuberosity. Radiographs usually show soft tissue swelling and loss of the sharp margins of the patellar tendon in the acute phase, but it's important there's sort of a compatible history in making the diagnosis. There can be sort of later down the line bony fragmentation of the tibial tuberosity, but you can't equate isolated fragmentation of the apophysis with Osgood-Schatter's, as there's multiple sort of secondary ossification centres that could be around the same area. So the clinical history is important. Osteonecrosis or avascular necrosis can also occur around the knee. There are conditions that would predispose people to this, including long-term steroid use, alcohol intake, lupus or sickle cell, and has a plethora of plain film findings that range from normal to increased sclerosis to subchondral collapse and secondary osteoarthritis. This is a plain film and corresponding MR of the knee. MR radiograph showing multiple sort of ill-defined sclerotic lesions, including up to the articular margins of the knee, and on MRI multiple sort of geographic regions of abnormal bone marrow with a rim sign, which are more evident in the femoral condyles. Suggesting osteonecrosis and bone infarcts. Baker's cysts are fluid-filled synovial lesions arising in the popliteal fossa between the medial head of the gastrocnemius and the semimembranosus tendons, communicating with the knee joint. So, medial head of gastroc, semimembranosus with Baker's cyst here. Can be associated with osteoarthritis, rheumatoid arthritis, and trauma. Sort of bimodal peak at a young age, and then again between the years of 35 and 70, often seen incidentally, but can cause symptoms if they rupture. Nicely seen on ultrasound. We've seen the between the semimembranosus and the medial head of gastroc, this fluid-filled anechoic hypoechoic lesion, smoothly marginated, consistent with a Baker's cyst. Osteoarthritis, again, can occur around the knee. Similar findings to where you'd see osteoarthritis elsewhere, where there's joint space narrowing, subchondral sclerosis, subchondral cysts, osteophyte formation, and spurring of spurring. You can also see on lateral projection loss of joint spaces, but also loose bodies within the joint, and osteophyte formation in multiple compartments. MRI is particularly good at looking for internal derangements of the knee, better so than other modalities. The ACL is the most commonly disrupted knee ligament, particularly in those with who play sports with rapid stopping and pivoting motions. with patients typically presenting with symptoms of knee instability, usually after trauma. Clinically, the ACL can be tested with Lockman pivot test and pivot, shift, and anterior draw tests, and on MRI can be seen as either direct or indirect signs. Direct signs being fiber discontinuity and laxity, and avulsion fractures of the intercondylar eminence of the tibia. Indirect signs include bone contusions or impaction fractures, joint effusions, and anterior tibial translation, as we're seeing here. PCL injuries account for about 10% of knee injuries and are commonly associated with other ligamentous injury, meniscal tears, and postero-lateral coronal injuries. Have a mechanism that involves hyperflexion of the knee from high velocity forces, so seen in people who are slide tackling or soccer, but it can also be seen in car accidents with dashboard injuries. On MRI, the PCL usually remains contiguous, although there might be partial disruption. We can have an enlarged or swollen PCL with greater than 7 millimeters in diameter of the vertical portion on sagittal is imaging indicative of a tear, just like with, or I guess analogous to ACL injuries, PCL injuries can have posterior tibial translation. MCL injuries can range from strains to complete tears, and they're one of the more common forms, more common knee injuries. They're very common in athletes, and the usual complaints are of medially located knee pain following acute trauma with a sensation of popping or giving way. Clinical exam would show a medial joint opening in valgus stress. Plain films and CT are of limited value, although sometimes you can see a avulsion injury. The most obvious sign of MCL injury on MRI is complete or is discontinuity of the MCL, as we're seeing here. MRI also allows detection of bone contusions and other associated injuries like ACL ligament injuries and meniscal tears. Grading is usually into 3 groups. Either a minor sprain, which is a high signal medial or superficial to the ligament, severe strain or partial tear, where there is high signal medial to the ligament and high signal or partial disruption of the ligament, and grade 3 being complete disruption of the ligament. Meniscal injuries are relatively complicated and probably not something that can be completely covered in this lecture. There are several types of them, both simple and complex, and can either be post-traumatic or degenerative. A longitudinal or vertical tear occurs perpendicular to the tibial plateau and parallel to the long axis of the meniscus, which divides the meniscus into a medial and lateral parts, being a longitudinal tear. A horizontal tear or a cleavage tear is oriented parallel to the tibial plateau and involving one of the articular surfaces or the free edge of the meniscus. Divides the meniscus into a superior and inferior part. A radial tear is perpendicular to both the tibial plateau and the long axis of the meniscus. And a complex tear is a combination of horizontal, vertical, and radial type tears. The bottom 3 images here depict displaced tears. A bucket handle tear is a displaced vertical tear. A parrot beak tear is an oblique radial tear. And a flap tear is a displaced horizontal or vertical flap tear is a displaced horizontal or vertical tear. Plain films and CT are usually unhelpful in diagnosing meniscal tears. MRI has a relatively high sensitivity and specificity for meniscal tears and is the modality of choice when meniscal tear is suggested, with sagittal images being the most sensitive. Normally on MRI, the menisci appear black and tears appear as high signal that extends to the articular surface on at least two slices, which don't have to be contiguous. So if you can see it on a sagittal and a coronal slice, then you can call it a tear. You also need to see distortion of the normal meniscal morphology. There are some associated features that you can see, like parameniscal cysts or meniscal cysts, and subchondral bone marrow edema as well, or meniscal extrusion. And there's a grading system for meniscal injuries as well. So here we can see a horizontal meniscal tear. We can see there's a horizontally oriented line of increased signal within the meniscus, which extends to the inferior articular surface near the free edge. And that brings us to the end of our knee lecture. Thank you.